Our first speaker this afternoon is an experienced executive officer of health and social services, non-profit and charity organisations. He's currently Chief Executive Officer of the New South Wales Rural Doctors Network. He's a strong advocate for social leadership and has a professional interest in building contemporary business practices of not-for-profits to enhance the sector's impact and benefit for communities. He has a commercial background in strategy, partnerships and program management, and values multi-agency and community collaboration that brings together strengths and competency of each partner for mutual benefit. And I've seen that in practice. Richard's he's a great connector of people. So I give you Richard Colbran, who's going to speak about embracing carers within the New South Wales rural health workforce.
Fantastic. Thanks, Lana. Thank you for having me with your conference, and also the opportunity to speak with your friends, your members, and those involved in caring across New South Wales. It's a privilege to be today's session, and congratulations to your team for bringing it together in these difficult times. So my name is Richard Colbran. I'm the Chief Executive of the New South Wales Rural Doctors Network. I've been in this role for nearly 5 years, and in preparing for today and the title of my presentation, which is Embracing Carers within the New South Wales Rural Health Workforce, I've been reflecting a little bit that we probably met nearly over 3 years ago on the back of a conversation that we had in relation to the role of carers within the New South Wales Rural Health Workforce. So I don't normally get too nervous, but I'm a bit nervous today because I actually see that this is the culmination of those 3 years of conversations that we've had. We've taken our time to understand the work of each organisation and the needs of community. And I'm really hoping that today I can bring something new and interesting to your people, but also at the same time, I think I've got my L plates on and we're looking to learn a bit more about the needs of carers across the community, and also how we might be able to help you and your people and those that you care for. So yes, I'm hoping that today it gives us an opportunity to continue that relationship that we've been building, and I bring some information and some good new knowledge for you all as well. I'm on Gadigal land today, and I'd just like to acknowledge the traditional owners of all the lands across Australia, particularly those outside of metropolitan cities, and pay respects to elders past, present and emerging. And I really did enjoy Uncle Alan's welcome to country today, and his conversation that he spoke to, and the idea of walking with people, trusting people, respecting the need for leadership and the need for commitment. As a non-Indigenous Australian, one of the things that I've come to learn through the privileges of the roles that I've had is that I've been able to make some wonderful friendships with First Nations peoples across Australia, and continue on my own journey of learning about truth-telling and the importance of understanding Australia's history and culture and identity as well. And I think in any conversation that we have about health in remote and rural Australia, we cannot do that conversation without considering the impact of colonisation, and also what the next generations will bring, and the roles that we have as leaders in supporting our Aboriginal and Torres Strait Islander friends and families. So today, what I'm going to be talking to you about is this idea of trying to get our head around, as a health organisation, working to support access and health access to community, is where possibly we can connect and engage and support those that are caring in community to participate in the health system. And obviously the end result of that being better access to support for those that are in need in our community. I've broken every rule in the book here with this slide, but I know that this slide deck will be shared post the conference. And so I thought just having this here as a sort of a capstone of what we'll be exploring in the next 20 minutes was quite useful and important. And again, I'll just go back to this idea that I'm really also hoping to open up a conversation with those of you across the state and the country that are working in the caring space to try to understand how we can do more to support your efforts. So the way that we've constructed our presentation today is to give you a little bit of context and construct to who the Rural Doctors Network is, our role, our work and what we do, explain to you and show you some of the things that we do in terms of our evidence and how we build and prepare for services into the community, and then also go into some 4 or 5 specific examples about the work that we're doing, and again try to unpick or understand whether any of this type of work can add value to you, either in community or in your homes, at a regional level, and also then across each of the states and jurisdictions. So RDN, So the Rural Doctors Network of New South Wales is a not-for-profit organisation. We're a charity. We were established in 1988 after as an outcome of the New South Wales Rural Doctors Dispute. And the Rural Doctors Dispute came about because the doctors were being paid the same amount of money as administration or cleaning staff to come and deliver a baby at midnight. And that led to this, the first of its kind, this doctors dispute. And there were a couple of things that happened in relation to that. And I thought this was important, or this may be interesting to share, is that the industry of rural health didn't actually exist back then. It was all very new. And two things happened in 1987. And one was that the industrial lever, the employment mechanism called the Rural Doctors Settlement Package, was created by the New South Wales state government, which led to, and that document still exists today. It's still in place over 30 years later. And then the second thing that happened was the state government of New South Wales invested money in the support for the recruitment and retention and wellbeing and training and education of medical staff outside of Sydney. That investment led to the creation of the Rural Doctors Network, and here we are today, 30 years later. Interestingly, I'm only the second chief executive of RDN. Our founding CEO, Dr. Ian Cameron, was in place for over 28 years at RDN. So there's this incredible richness of history in our organisation and the relationships that we have across the state. And it is a real privilege to participate and be involved in those conversations. I'm sort of driven by community. I'm driven by people. I'm not a health worker. I'm actually a failed PE teacher, I tell people. And what I've come to see over the 20 years of my time working in the not-for-profit sector is I'm inspired by people and community. And what I love about working at RDN is the fact that we're actually not really a health agency, although our name might suggest that it is. We're actually about communities and about people. And the critical point on this slide is actually this top point. It's around rural health access. So what I've come to see in the last 4 or 5 years, and probably in some roles previous to that as well, is people talk a lot about get us a workforce, get us a service, and all these types of things, and become very particular and very tactical about an individual component of what they need. But the way that we see, and RDN's been worked on this for over 30 years, is actually if you frame the conversation about having access to healthcare, no matter where you live, if you frame the conversation about access first, everything else flows from there, because it's actually the access component that's most important. And we always say access to quality healthcare as well. For those of you that are based in metropolitan areas, the other thing that we like to talk about in framing the conversation around rural health is actually to look at 3 very distinct geographical separations, and that is remote, rural, and regional. So quite often you hear the phrase rural health, or in New South Wales's context, regional health. But what we know from our work is those 3 separations, remote, rural, and regional, are very, very different. And the dynamics and how towns work based on those 3 separations is very different. And quite clearly, the health system and the social services sectors all work differently across those 3 types as well. So everything you hear from me from this point forward is around thinking about access. And you'll see a slide shortly where we talk a little bit about what is the role of carers in supporting and enabling access to healthcare. And I think that's the thing that I'm probably most excited about in terms of the conversation with Carers New South Wales and all of your partners in relation to what this could lead to, is that clearly if 1 in 9 people in Australia formally identify themselves as a carer, it's a significant component of the health system and hopefully the health workforce that we might be able to support. So the other thing that we do at RDN is we talk a lot, it's a little bit academic, but we talk a lot about the concepts that we think are important to support that access to care. In health, so many of our organisations and service providers rely on contracts, whether it's a Medicare contract and billing all the way through to government grants. And what I've come to see in my time in the not-for-profit sector is while that's very important and it's how you sustain in your organisations and you build tenure and continuity of services, one of the risks of contract thinking is that you become beholden to that contract or those contracts. And I think you tend to lose some of the innovation and the spark and the zoom that comes from actually what drives most of our sort of organisations, and that is about people. So what we've been working on over the last 3 or 4 years is bringing forward evidence into the way that we do work and having some assessments and drivers around the impact that we have using these theoretical concepts. And I've listed some of those there. Now, in preparing for today, I've actually, I'm looking forward to exploring this further with Lana and the team more later, is there's 2 or 3 of these that are really interesting for me. One's around capability, the workforce's capability. One's around health workforce literacy, and the other is around working in partnership. I won't sort of talk too much about partnership now, but workforce capability is very interesting for me. In what I've come to see, particularly working with medical people across the state, is that they judge themselves and others about whether they are clinically competent. And so they're very harsh on each other. And I wonder a bit too if that's the case for carers. So already the conversations I've heard this morning appear to be about people sort of being worried and concerned about their capability to actually provide service to their loved ones and others. Whereas what we've come to see is actually in rural and remote, for people to be retained in providing health service in rural and remote settings, it actually isn't about clinical competence. What drives them is actually the whole of themselves and the whole of the person. And we've come to see that if we can support capability looking at the whole of the person, be they physically well, spiritually well, professionally well, and all the things that make up that person, if we can help them in that whole sense of the whole person, that they're likely to stay longer and they're likely to come and be ready to and be sort of tool ready to get involved. So we do a lot of work around looking at individuals. We do a lot of work about not looking at individual health workers as cases. So it offends me in health that we talk about people as cases. We talk about people as talent, and we do a lot of work around capability. And I wonder, actually, what I've been thinking about the carer situation is whether that capability component might be interesting for you as well. The other that I wanted to talk about here, and I'm mindful of my time, is around health workforce literacy. It's a bit of a play on words, if you like, around health literacy. But what we've come to see, or I've come to see, is that health workforce planning is actually a science. It's very complicated. I don't fully understand it myself. I'm trying, but it's very, very complicated. It's very nuanced, and it's very town and locality specific. We sort of say, if you've been to one country town, you've been to one country town. In some places, you might have 3 speech pathologists. In others, you might have no speech pathologists within 300 kilometres. So it's very much a nuanced approach, and it's a bit like a science. But what we know is that if we can have more people understanding the challenges of building a health workforce, the way that local communities participate and can succeed in securing a workforce and supporting and enabling that workforce, so they're more literate about what it takes, that we think that will have greater success as well. And again, I think the carers notion will be part of that thinking moving forward. I'm going to explore some more of the points here as I go through these next slides. But again, I'm very happy to take any questions, and really do hope that you might be able to give me some feedback via phone calls or online after the session as well. This is a dense slide. Really what I'm trying to do here is just show you the type of work that we do. So despite our name as the Rural Doctors Network, we actually work across all health professionals. Our job is to build, grow and sustain, attract, recruit and retain, and I now say preserve as well, our rural health workforce across New South Wales. And there are similar agencies across the country that do similar work as well. And we sort of band together and call ourselves rural workforce agencies. And so I can share you more information for those that are interested outside of New South Wales as well. So there's a whole host of work that we do, but our primary driver is probably 3 things. First thing is to assess ourselves and our success on the resilience and the sustainability of health services within remote and rural communities, and sometimes regional as well. And quite often there are 2 factors that make up that resilience of a health service locally. The first of all is the workforce shovel ready, and is that workforce fit for purpose to serve the health needs of that community? And the second thing is, are the service models that are in place appropriate for the needs of that community as well? And so we do a lot of work around evidence building and data assessments and community engagement to assess and support the development in that first impact area. The second that we work on is building the pool of health workforce. And that's one of the reasons I think I'm so keen on learning more about the carers network, is because if we can build a highly engaged, highly capable, highly energized health workforce, that is going to help everybody. And so that's one of the things that we're looking at. And I've got a slide to show you more on that shortly. And the third is about that capability aspect. The more capable our people are, whether they're volunteers or they're paid or they've just got general interest in health, the better our system will be. So this is the slide that I wanted to get to show you a bit more about how we're building our planning and our approach over the last 3 or 4 years since I started at RDN. This doesn't say one of these workforce cohorts is more important than another. It actually probably relates more to the fact that we're trying to grow and develop our thinking in terms of how to engage and participate with limited resource with various workforce cohorts. And you'll see their carers, and hence why after 3 or 4 years, here we are today. And again, thank you to Carers New South Wales for your patience with me as we've sort of built this sort of framework in our work in terms of talking and engaging with health workforce people. The next couple of slides, I won't talk a great deal to, but I wanted to give you some confidence about, again, the theory or the science behind and the evidence behind how we go about assessing health workforce need and health workforce capability in communities. This is a framework that Rural Doctors have developed many years ago, and it talks a little bit about the 3 critical drivers or factors or components of that idea of sustainability within a local region in terms of workforce and service modelling. And we particularly look at things like access, quality and sustainability. Every year, the Rural Doctors Network produces a public document. It's called our Health Workforce Needs Assessment. That's available online, and I'm happy to share that to anybody who would ask, but it is on our website. And that looks to articulate the current state of play of health workforce across the state and identify the most vulnerable areas that we need to invest, all of us as a sector can invest effort to support. And we use that framework to sort of build on that. Here's another conceptual framework. This was for Western New South Wales. I'm going to show you a slide shortly. Over 50 organisations are currently participating in a health workforce concept project for Western New South Wales using this model just here. And again, we can share this to you. And it looks at the primary goals around how to attract and retain a workforce, thinking about people, thinking about place-based thinking, how to develop engagement within the community, and also being accountable to performance across those organisations. It's a very innovative project, and it's something that I think I'd like to introduce to Carers New South Wales. There's the list of the people and the organisations that are participating in that very significant project in Western New South Wales. And one of the things I like talking about is the idea of enabling the current resources in the system rather than just always having our cap out asking for more money. When you think about all the resource that's in all of those organisations, we all have an interest in doing better, and we all have we must come together. The aggregation, the sum of us, is what creates great success, not working individually in a siloed manner. And we're seeing that happen in Western New South Wales currently. This is, I've only got a few more slides to go. This is our Health Workforce Needs Assessment and some of the work that we do there. As I said, that's available online, and I'm hoping in the year ahead, so the 2021 version, which would be released in April, that we're hoping to have a chapter specifically relating to carers in that document, and hence again why we're talking today. That needs assessment always produces sort of maps and spatial maps of exactly what's happening across the state. These are some of the maps that we see. This is particularly looking at the GP workforce, and the bottom one in the right-hand corner there is actually, or in my right-hand corner, is actually about allied health. So we can identify, service need, population need, and workforce availability across the whole of New South Wales, and identify where, as I said, our limited investment might go in supporting recruitment and retention efforts. In these final couple of slides, I just wanted to show you some of these examples. So one's around town-based planning, and I thought this would be most relevant for today's conversation. So across New South Wales, there's about 1,000 medical systems or health systems across rural and remote New South Wales. There's about 330 what we call medical hubs. Many more towns, obviously, but sort of based around these health hubs, if you like. And at any one time, it's about a third in terms of those that in a traffic light model would be green in terms of functionality, orange or red, where there's some concern. And at any one time, there's about 20 to 25 that are flashing red. High worry, high crisis, emergency needing response needed in terms of workforce or service modelling. Our goal is to try to reduce that number down and have as many as possible heading towards the green end of the scale, but that's not always easy. Now, at the moment, I have not In 5 years, I've not been involved in a town-based plan that carers have been spoken about. And I'm interested in that. And again, one of the reasons we're so keen to keep speaking with you all, because I suspect there are carers in those towns. I suspect that there's strong caring networks in those regions. And I suspect that if we are able to bring you into the fold, embrace you into the fold, that all of our people and our communities will be better for that. The last thing I wanted to show you today was actually this tool called Rural Health Pro. There's a bit of an invitation here, if you'd like, and I'd just like to explain what Rural Health Pro is and where it's come from. So Rural Health Pro, so as the Rural Doctors Network, our job is to connect and engage and support the whole health workforce, as you saw in that earlier slide. One of the problems we've got is our name, because when people hear the phrase doctor, they tend to switch to thinking just about doctors, but our constitution talks quite clearly about working for all. And what I find is that the doctors that are a part of our network are actually, they would put community first. We're not actually a doctors organisation, we're a community first organisation. But the problem we've got is if people ring us as health workers, they think they're ringing the doctors. So what we've done is we've set up a program of work called Rural Health Pro. And it's an online community forum. It's got its own app called Rural Health Pro, and you can go into Rural Health Pro today and log in and sign up. And what we've done today, just to try to test this for you, is we've actually set up a community group for carers. So you'll be asked to click the carers box, and you'll also then be led into a community discussion forum for carers. And what I'm hoping is, if that's of interest to you, that might be the place, in partnership with Carers New South Wales, that we might be able to start sharing with you intelligence and information and knowledge that we've got around what's happening across rural communities. And you'll also be able to share back to us your thoughts and thinking about what's important for you in your work. So it's ruralhealthpro.org, and feel free to log there after the conference, obviously, not to distract you, but that's there for you. So I know I'm running a bit short of time. I've got a couple of other slides here, but the last thing I'll do, though, is just share with you this. So I do think carers are part of the health workforce. I first learned about this about 6 months into my job at RDN, where I saw a presentation from Germany in relation to how they think about carers as being part of the health workforce. And that was what inspired me to get in touch with Alana, and she's been wonderful, and the team's been wonderful since then. But as I said, we weren't quite ready, and we are ready now, and I'm really hopeful that we can continue our conversations and try to build something here together. What is going to happen during November is, on behalf of the sector, RDN is coordinating and facilitating a thank and praise campaign to say thank you to our health professionals. And I would like to include carers in that as well, if you give me permission for that. Last year, on the back of COVID, we had many people saying, well, we need to say thanks to the health workers for all their effort through COVID. The thing that I think people forget in the terms of the remote conversation, rural and remote conversation at the moment, it isn't just about COVID. We've been through 4 years of drought. We then had bushfires. We then had COVID. We've had mice. We've had a flood. We're now back to COVID. Our health teams are exhausted, absolutely exhausted. What we have to deal with is, in heading into 2022, we need to accept that we've got 2 to 3 years of recovery to come, and we can't let the conversation just drift off as we come out of COVID. So with our health partners and carers as well, what we're going to do during November is run a public campaign just to say thank you. Our rural health professionals don't want to be called healthcare heroes. They want to do their job. They want to be safe doing their job. But we think, so we're not going to do healthcare heroes. We're just going to say thank you. And we'll start to publicise that probably in the next fortnight. And I hope for all of you who are carers or involved in the caring network can take some comfort and encouragement and inspiration that we're thinking of you as part of that health network, that health professional network. And that's the way for me to finish off today, by saying thank you to you. So many of you do so much work. I've got my learning plates on, as I said, about how your network works and who you are and what you're dealing with. But at the end of the day, you are part of the greater team, and we're just so thankful for the effort that you all give. Thank you.
Fantastic. Thank you so much, Richard. We really look forward to working with you into the future. And I think you've raised some really interesting issues. We have run out of time for questions, but what we'll do is that any of the questions that have been posted, we'll get back to people and certainly provide links to the presentation and also to Rural Doctors Network and all of the things that you mentioned today, because I think it is the start of a further conversation and a further look at how we incorporate carers into the rural workforce and everything else. So thank you very much. That was fantastic and a great look at, remote, rural and regional.